Good morning. Let's go ahead and get started with Grand Rounds this morning. It's my pleasure to go ahead and welcome one of our chief residents, Roberto Martinez, who's going to be talking about cystic lesions of the pancreas. Dr. Martinez grew up in El Paso, went to Fordham University in New York for his undergraduate, and then went to Jefferson in Philadelphia for medical school. And then after that, he has spent the rest of his career in San Antonio. During his 5 years of general surgery residence, he also spent 1 year additionally in the lab. Please help me welcome Dr. Martinez.
All right, good morning. Thank you for the introduction. I'll be presenting cystic neoplasms of the pancreas this morning, a topic that I picked for a couple reasons. One, it shows up on the ab site every now and again, and two, I don't particularly enjoy studying it, so I wanted to get out of the way. I have no financial relationships to disclose, and today I'll be briefly reviewing non-neoplastic cystic lesions as a part of the differential diagnosis of pancreatic cystic neoplasms, also known as PCNs, and provide an overview of PCNs, including epidemiology, presentation, and workup, with a focus on diagnosis/management of lesions with malignant potential, emphasizing branch duct IPMNs, and also review the literature and consensus/evidence-based guidelines available to us currently. Broadly speaking, we can group cystic lesions into two categories. One, non-neoplastic lesions, which are mostly comprised of pancreatic pseudocysts, and neoplastic lesions, which include multiple subtypes arising from the exocrine pancreas and can be malignant or benign with variable potential for transformation. Beginning with pancreatic pseudocysts, as we know, they're found in patients with a history of pancreatitis, and acute fluid collections will develop in 50% of these patients during a attack, 10% going on to develop a cyst. These fluid collections are caused by a disruption of the pancreatic duct during the attack, resulting in a localized fluid collection, which is rich in amylase and other pancreatic enzymes. It's important to note that the wall of the cyst is non-epithelialized and composed of fibrous and granulation tissue, and that most of these will resolve if given enough time, in particular if they're less than 5 centimeters. Importantly, though, on our differential diagnosis, we need to include our cystic neoplasms, i.e. potential cancers, which can be confused for pancreatic pseudocysts in the right clinical situation. There are multiple treatment options that I bring up only to discuss in the context of mismanaging mucinous neoplasms. Endoscopic stenting for pancreatic pseudocysts has been successful, and also endoscopic cysgastrostomy. On the left, we see a picture of an open cysgastrostomy, and I bring this up to underscore the importance of establishing the correct diagnosis before performing this procedure, as in the literature there have been reports of diffuse peritoneal spread of mucinous neoplasms and patients with pseudomyxoma peritonei from marsupialization or drainage of mucinous neoplasm that was thought to be a pancreatic pseudocyst. PCNs were traditionally classified as cystadenomas with a malignant counterpart, cystadenocarcinoma, until the 1970s, when Campano and Ortel published 2 landmark papers in the Journal of Clinical Pathology, which described histopathologically different epithelium between pancreatic cysts. Over here on the right upper hand corner, this picture shows cuboidal glycogen-rich epithelium, which would later go on to describe serous cysts, and below we see a papillary epithelium with tall columnar cells which secrete mucin, which would give the cysts aptly give the cysts their name. Possibly more importantly, they noted in their series that these cysts have different malignant potential. Serous cysts are almost universally benign, while mucinous cysts often have various degrees of atypia within the same specimen, so they can have non-invasive, invasive components in the same specimen at different locations in the epithelial wall. In 1996, the World Health Organization classified these cysts into serous cystic tumors, mucinous cystic tumors, and the very rare solid pseudopapillary tumors. However, it gets to be a little bit lengthy when looking at this list, and I think a more reasonable and logical way to classify these cysts is by the production of mucin by their epithelium. given that that's what gives them their malignant potential. Non-mucin producing cysts include serous cystadenomas and solid pseudopapillary tumors, whereas mucin producing cysts, mucinous cystic neoplasms and intraductal papillary mucinous neoplasms, or IPMNs, represent mucinous producing cysts. Overall, there's been an increased interest since the landmark paper given their malignant potential, and they're being diagnosed with increasing frequency owing largely to improved imaging and increased awareness. It's estimated that the prevalence of these cysts is about 2% of the population, which increases with age to about 10% of patients over the age of 70, which would, in 2 studies examining autopsy specimens as well as MRIs obtained for non-related reasons. Overall, though, they have a low risk of malignancy. It's estimated that between 0.03% and 0.2% of the population are walking around with mucinous neoplasms in their abdomen, according to the SEER database published by the NIH and the National Cancer Institute. Originally, it was thought that pancreatic pseudocysts were accounted for greater than 90% of all cystic lesions of the pancreas, but now it's thought that PCNs comprise almost or greater than half of them. As a whole, PCNs occur more frequently in women, though IPMNs have equal gender distribution. As a general rule, they're often found incidentally, estimates of up to 70% in the literature, or they can cause nonspecific complaints such as dull abdominal pain, nausea, or vomiting. It's important to also note that the mucinous subtypes can cause clogging of the main pancreatic duct and present as pancreatitis, or patients with pancreatitis can also have incidentally found cystic lesions on imaging. With regards to frequency of different types of PCNs, IPMNs are the most frequent, accounting for up to 40% of lesions, of which nearly 60% are of the branch duct variety. We see that from this figure that mucinous neoplasms are more common than their serous counterparts. So just to review what I've said very briefly, serous cysts are accepted as benign lesions. Mucinous lesions are more common than non-mucinous lesions. All mucinous lesions have malignant potential, and they exhibit a spectrum of aggressiveness, including benign, invasive, and non-invasive components in the same specimen. And of these lesions, branch duct IPMNs are the most frequently. So potentially malignant cysts are more common than serous, universally benign cysts. So this leads to our dilemma. We have an increasing rate of incidental diagnosis in asymptomatic patients of a disease process with multiple classes of neoplasms with variable malignant potential, and overall a lack of strong evidence-based practice guidelines to assist us in caring for these patients. So in approaching these lesions, as always, it's important to take a careful history and have a high index of suspicion, and employ appropriate advanced cross-sectional imaging when indicated. MRI and MRCP provide a more detailed evaluation of the main pancreatic duct. However, CT pancreas protocol is acceptable in some institutes. Endoscopic ultrasound and fluid analysis, checking for cytology, tumor markers, and molecular markers is also one of the advanced studies that we employ to work up these cysts. With regards to MRI versus CT scan, these cysts can be difficult to distinguish from pancreatic pseudocysts on routine CT abdomen pelvis, requiring more advanced imaging in the form of CT pancreas versus MR. In 2010, the American College of Radiologists published their consensus guidelines recommending that we use MRI, MRCP as the imaging test of choice when evaluating a lesion suspicious for neoplasm, given its superior contrast resolution, recognition of septate and mural nodules, and greater ability to evaluate for main duct communication. I'll begin first by talking about non-mucin producing cysts, serous cystadenomas, and solid pseudopapillary tumors. As a general rule, as I mentioned, serous cystadenomas are a benign lesion. They have a strong female preponderance of up to 75% in some studies, and although they're often incidentally found, their symptoms can cause symptoms via mass effect and present with a palpable abdominal mass. These cysts arise from central acinar cells, can occur in any part of the pancreas or replace the entire gland, and usually present as multiple cysts. Although in approximately 10%, the oligo or macro variant is present, and it can be confused with other processes like pseudocysts, branch duct IPMNs, and MCNs. On radiology, they'll display a microcystic or honeycomb appearance and have also been described as grape-like clusters. These cysts are formed from a collection of well-circumscribed cysts in a fibrous capsule demonstrating central calcification, and in 20 to 30% they'll exhibit a stellate scar from convergence of their fibrous septae. And by definition, they have no communication with the main pancreatic duct. In addition to serous cystadenomas, solid pseudopapillary tumors are included in non-mucin cysts of the pancreas. They account for 3% of all PCNs, making them an exceedingly rare tumor with a prevalence in the population of well less than 1%. Although they are also more common in females, they have a much younger presentation than other cystic neoplasms of the pancreas and can become very large and symptomatic. They'll demonstrate solid and cystic components on CT and also have calcifications and carry an estimated risk of malignancy of about 15% in the literature. Garnering more attention owing to their malignant potential, mucin-producing cysts, Mucinous cystic neoplasms also have a female preponderance, present in the fourth or fifth decade with vague symptoms, and are almost always located in the body or tail of the pancreas. As I mentioned previously, what makes them interesting is their epithelium will display various degrees of atypia. So as you might imagine, if you take a biopsy of the wall, you could miss a frankly invasive component. Classically on biopsy, they will demonstrate subepithelial ovarian-like stroma, which is classic for their diagnosis. MCNs present as single lesions. They do not communicate with the main pancreatic duct, and their estimated incidence of invasive carcinoma is up to 1/3 in some studies. In the literature, increasing age, calcifications, mural nodules, and cysts greater than 4 centimeters have been shown to be predictors of malignancy. And they carry a variable prognosis with 5-year survival rates for invasive cancer ranging from 20 to 60%. On imaging, you'll see a unilocular fibrous capsule encircling the cyst. They can often be confused with pseudocysts, pictured below. But one of the ways to tell the difference is by these eccentric calcifications we see in the bottom left-hand corner, those bright spots along the periphery of the cyst. Perhaps the most controversial of the cystic neoplasm IPMNs come in 3 subtypes, the first being main duct IPMNs, defined by segmentally or diffusely dilated main pancreatic duct greater than 5 millimeters. The branch duct variant also includes cysts of greater than 5 millimeters that do not communicate with the main duct, and often they are multiple. And as the name implies, mixed IPMNs have components of both. Contrary to other neoplasms of the pancreas, they demonstrate an equal gender distribution and are believed to follow the adenoma-carcinoma sequence, but to be genetically and clinically distinct from adenocarcinoma. This is based on one study on the expression of DPC, a transcription factor involved in the cell cycle that is routinely deleted in primary ductal adenocarcinoma. Overall, they are less invasive with favorable survival compared to primary ductal adenocarcinoma. But as you would imagine, resection for invasive cancer carries a much worse prognosis. And to further compound the problem, we don't really know exactly how long it takes for IPMN to go from an adenoma to an invasive cancer, though one study based on age at diagnosis estimated about 5 years, given that the patients diagnosed with adenoma were 63 years old, and invasive cancers were diagnosed later at about 68. Not a perfect way to estimate time, but it was the only one that I found. Because of their malignant potential, a lot of attention has been paid to distinguishing which types of these IPMNs carry the worst prognosis and the highest incidence of invasive cancer. And we know that their malignant potential varies by classification, with mixed IPMNs carrying about a 45% chance of invasive malignancy. Similarly, main duct IPMNs have a 43% chance, while branch duct are by far have the lowest incidence of invasive cancer, suggesting that involvement of the main duct has significant prognostic value. Briefly, I just wanted to touch on histopathology, only to mention that the cell lineage of the papillary component in IPMNs carries prognostic significance. There are 4 cell types you'll see: gastric, intestinal, pancreatobiliary, and oncocytic. Gastric is most typically seen in the branch duct variant, while intestinal in the main duct. Invasive cancers typically come in two types, colloid being the one with better survival, but tubular the more common throughout the literature. So now we have another dilemma. The most common cysts that we see are well established to have malignant potential, but they have varying degrees. Invasive cancers confer a much worse prognosis, particularly in the IPMN subset. So once faced with a lesion suspicious for neoplasm, how should we proceed? Or more specifically, given the significant morbidity of pancreatic resections, who needs surgery versus observation? Over the past decade, there have been several guidelines published to try to answer these questions, beginning in 2006 at the Convention in Japan. Tanaka et al. Published the first international consensus guidelines for the management of IPMNs and MCNs. And initially, they recommended that cysts greater than 1 centimeter need further workup and assessment for what they called high-risk stigmata that I'll talk about in a few minutes. Conversely, asymptomatic cysts less than 1 centimeter required repeat imaging in 1 year, and if stable, no further surveillance. In 2007, the American College of Gastroenterologists published guidelines for the diagnosis and management of PCNs as a whole, and in 2012, the same group from Japan revised their guidelines and lowered the threshold of main pancreatic duct dilation to 5 millimeters, and also established worrisome and high-risk criteria for branch duct IPMNs as they provide the greatest diagnostic and treatment difficulties. Most recently, in 2015, the American Gastroenterological Association published additional guidelines for management of asymptomatic PCNs that were intended to be evidence-based, but unfortunately, all of the evidence they found, according to their PICO and grade criteria, were graded as very low. Given that they are the most frequently observed and carry the lowest incidence of invasive cancer, further characterizing branch duct IPMNs and figuring out which ones are concerning versus more benign appearing has been a focus in the literature. And as I mentioned, in 2012, the Tanaka group established high-risk stigmata and worrisome features based on both clinical and radiographic characteristics of the cysts and their presentation. Jaundice with a pancreatic head mass as well as abdominal pain were found to be independent predictors of malignancy in the literature after being validated by one study. Radiographically, main pancreatic duct dilation greater than 1 centimeter without other explanation, enhancing solid components within the cysts and enhancing muronodules are also categorized as high-risk stigmata. Worrisome features prompting further workup include pancreatitis, as I mentioned, and also cysts greater than 3 centimeters with enhancing walls or non-enhancing mural nodules. In addition, abrupt changes in the main pancreatic duct with distal atrophy and lymphadenopathy prompt further evaluation. This is a picture of the algorithm that was published in 2012 that looks a bit convoluted and confusing, but I think that it can be best summarized in 3 statements. All patients with high-risk stigmata should undergo resection without further testing. Worrisome cysts and those which have undergone significant changes being defined as increase of the main pancreatic duct or development of solid components or mural nodules, warrant further evaluation, typically in the form of endoscopic ultrasound and surgical consideration. Small cysts less than 3 centimeters without worrisome features can be observed at varying frequencies with different radiographic modalities. EUS is one of the advanced studies that we use to characterize these lesions when they display worrisome features. The main benefits to EUS are its high-resolution assessment and the ability to confirm or further characterize mural nodules or other worrisome features, and also the access to cyst fluid. Risks associated with this procedure include pancreatitis and spillage of mucin and diffuse peritoneal spread of neoplasms. The Japanese group in 2012 actually recommended against aspirating any cyst with worrisome features over concern of spillage of mucin. But this varies throughout institutes, and in discussing this presentation with one of the GI faculty at the VA, she routinely aspirates all cysts. So when you do aspirate the fluid, there are 2 objectives. One, you want to establish mucinous versus non-mucinous neoplasms, and this is done with the CEA level. It distinguishes mucinous from non, but is not able to distinguish benign from malignant. A level of greater than 192 is diagnostic with a sensitivity of about 80%. This is based on various studies throughout the literature that essentially just adjusted the level until they found the number that included a sufficient amount of neoplasms in diagnosis. Amylase, however, has plus or minus utility in evaluating mucinous neoplasms and is actually better at confirming serocysts or excluding pancreatic pseudocysts. Our second objective, establishing malignant versus benign cysts, is accomplished by cytology to varying degrees of accuracy. Positive cytology, i.e. overtly malignant cells, unfortunately only has a sensitivity of about 28% for histopathologically confirmed cancer in surgical specimens. This is probably owing to the technique for fine needle aspiration, where a small 22-gauge needle is used to aspirate cells, smear them across a pathology slide, It's logical to think that you could probably miss some cells in that sample. But one of the other studies in the literature included high-grade epithelial atypia as their cutoff for diagnosing cancerous lesions. And the sensitivity for detecting in situ or invasive malignancy in surgical specimens was actually increased to 72%. Molecular analysis is investigational at this point, not commonly performed, but the KRAS gene has been shown in some studies to be associated with mucinous neoplasms. So now that we've defined our lesions, how do we manage them surgically? Essentially, and broadly speaking, the surgical management of these lesions is dictated by how malignant they are. Serous Cystadenomas are almost universally benign, so no resection or surveillance is indicated unless they become symptomatic regardless of how large they are on initial imaging. Solid pseudopapillary tumors, however, although they are non-mucin producing, should be considered for resection regardless of stage, based on the American College of Gastroenterology guidelines in 2007, due to their malignant potential, earlier presentation, and favorable cure rates, even in the setting of metastatic spread. As a general rule, all mucinous cystic neoplasms in surgically fit patients should be resected. This is the recommendation from two separate groups, largely owing to the fact that the natural history is still unknown. We don't know how long it takes for them to turn from non-invasive to invasive, and the risk of malignancy is thought to be cumulative. Of note, cysts less than 4 centimeters without mural nodules, i.e. those cysts with low risk of malignancies, can be considered for a laparoscopic approach, as they are thought to have a lower risk of spillage of mucin. IPMNs have more of a nuanced approach to their surgical management, but generally speaking, if the main duct is involved, resection is recommended for all surgically fit patients. This is a recommendation by the Tanaka group in both their 2006 and 2012 guidelines, which seem to be the guidelines that most surgical oncologists follow. They have a high incidence of invasive cancer and low 5-year survival, leading to this recommendation. But branch duct IPMNs, as I've mentioned, are the most commonly diagnosed neoplasms, but also carry the lowest incidence of invasive cancer. So more conservative indications for resection are employed. They also occur more frequently in elderly patients. So when evaluating branch duct IPMNs, it's recommended that patients less than 65 with cysts greater than 2 centimeters be considered due to the cumulative risk. However, cysts greater than 3 centimeters without high-risk stigmata be observed. The size cutoff in this is a topic of a bit of controversy in the literature, and some studies have actually shown that a branch duct IPMN greater than 3 centimeters carries about a 30% chance of invasive cancer. If you include a mural nodule to that cyst, it goes up to 45%. And even cysts less than 2 centimeters had a 10% risk. But currently, the recommendation from the Tanaka group is that cysts greater than 3 centimeters without high-risk stigmata be observed.
Greater than 3 or less than 3?
Greater than 3 without high-risk stigmata. Multifocal branch duct IPMNs account for about 25 to 40% of specimens, and it is a recommendation that you resect suspicious lesions and observe the remaining pancreas at a frequency that I'll discuss momentarily. So to recap, all IPMNs involving the main pancreatic duct and mucinous cystic neoplasms should be resected if possible. Serous cystadenomas are rarely resected unless they cause symptoms, and branch duct IPMNs require the most extensive workup prior to resection and should undergo resection if they display high risk or worrisome features. Currently, the standard of care for surgical management of these lesions remains anatomic versus total pancreatectomy with lymph node dissection, with the obvious aim of complete removal with negative margins. The Tanaka group recommends that you perform these surgeries at highly specialized centers because of the need for intra-op frozen sections, as decision-making is often based on margin status. And in the absence of high-risk stigmata for some of these cysts, limited resections may be considered, as I mentioned, because of the decreased risk of leakage and pseudomyxoma. So in terms of surveillance, also a bit of a controversy, cysts less than 3 centimeters without a solid component or dilated main pancreatic duct, as well as cysts evaluated with EUS over initial concern, but found to have no concerning findings. You repeat the MRI in 1 year, then every 2 years for a total of 5 years. If the cyst remains stable or if the patient is no longer a surgical candidate, it's the recommendation that you can discontinue at that point. As I've mentioned a couple times, the management of lesions less than 3 centimeters without worrisome features is a bit controversial, as in some studies, 2 centimeter cysts have had up to 10% risk of invasive cancer. Postoperative surveillance after resection remains poorly defined. Mucinous cystic neoplasms, which are non-invasive, require no post-op surveillance, as they are generally curative resections. However, invasive MCNs surveillance, the surveillance of MCNs that are invasive mirrors primary ductal adenocarcinoma. This is imaging every 3 to 6 months for 2 years, and then annually thereafter. The surveillance for IPMNs, however, is based on your surgical margins. If you have negative margins, you repeat imaging at 2 and 5 years, although this is not evidence-based. But for low-grade or moderate dysplasia, you follow a biannual clinical follow-up and imaging, algorithm. Invasive cancers, the surveillance, as I mentioned, or the surveillance mirrors that of primary ductal adenocarcinoma and is imaging every 3 to 6 months for 2 years and then annually thereafter. So non-resected IPMNs present a bit of a challenge. They require open communication with the patient because you are obviously leaving a potentially invasive cancer in their abdomen. There's little to no evidence to guide the surveillance of these lesions, but without high-risk stigmata, it's generally accepted that you can obtain cross-sectional imaging at 3 to 6 months to establish stability, and then proceed with annual imaging labs and exam according to the size of the cyst. Less than 2 centimeters, I guess a good way of summarizing that would be the greater the cyst size, the more advanced your imaging gets. So if you have a cyst less than 2 centimeters, you can get CT or MRI. If it's greater than 3 centimeters, typically they recommend an MRI with endoscopic ultrasound. So to summarize, currently there is limited high-quality evidence backing any of the guidelines. All mucinous cysts have malignant potential and should be evaluated for resection. Serous cystadenomas are considered benign and almost never resected, and anatomic resection with lymphadenectomy remains the surgical standard. So I'd be happy to take any questions at this point.
Is your daughter worried about what you put in the water bottle, or hesitant?
She's asking for Shrek, actually.
So radiology really helped us dealing with lesions of the pancreas. CT scans with benign pancreatic pseudocysts, we never knew what the natural history was before that. And then obviously with MRI and MRCP helping us with these cystic lesions of the pancreas. One question that comes up a lot of times on the oral exams, whenever you're operating on a benign pancreatic pseudocyst, be sure and biopsy the wall. On a couple of occasions, we've had presentations here where the surgeon didn't do it, and it turned out to be a cystic neoplasm that was malignant. You don't want to do that on your boards.
At 2 or more areas, too.
Correct. And that picture you showed was really nice about showing you got to suture the back wall because it does bleed. Any questions for Dr. Martinez? Yes, Dr. Muir.
Rob, I thought that was a very nice review of this topic. It's always been a little confusing to me. You mentioned lymphadenectomy is recommended. Did you say in your talk how often lymph nodes are positive?
Actually, I didn't. That's a good question. I don't know the answer to that off the top of my head. It may be known, but off the top of my head, I don't know the answer to that.
Dr. Abergili.
Nice review, Dr. Martinez. A couple of questions you might be asked at the board, and particularly of Ms. Swanson, is that the in charge of the hepatobiliary at Women and Break. You probably have two favorite questions you usually ask. One question is, let's say you do an IPMN. An IPMN usually located head of the head and unseen process. You did a Whipple on the patient and the pathologist, and you have a positive margin. How do you proceed? This is number one question. Second question is, how do you deal with extra pancreatic IPMN? They could be located attached to the stomach, to the bile duct, to the liver, to the thyroid, any place. How do you deal with those?
So to answer your first question, that's actually not agreed upon. So I took a sampling of multiple surgical oncology faculty at other institutions because I'm starting to get up in years, and now I actually know people that are attendings. And I got three different answers. One was to surveil it just with imaging. The other was another was to irradiate the patient, but no one said to go back in after it.
How about the literature also mentioned, sometimes you have a positive margin and you're concerned and the patient go on, usually they are in their 70s, I'm talking about IPMN, and you follow them, this is disease indolent. And you have another group which is a negative margin and yet they recur. How do you explain this phenomenon?
That's a good question. I don't know the biology of the tumor well enough to speak on that.
Multiple.
And as you said, this is a brand new disease discovered in the 80s by Owashi and the OHM. Brand new, we're still knowing about this. We still have not unraveled the pathophysiology.
Dr. Root.
Does a history of benign pancreatitis, i.e. common duct-based or alcoholic, enhance the likelihood of these neoplasms appearing?
That has not been borne out in the literature.
The biggest problem that we're seeing now are octogenarians who are getting CT scans for some reason, and we're finding these lesions. And obviously, some are good surgical candidates and others are not. And so these criteria about who to explore are very, very important, especially with the main duct that you mentioned. For anybody who doesn't know Dr. Root is one of our original founding faculty and is famous for his trauma background and for the one who did his studies at Minnesota on diagnostic peritoneal lavage. Glad to have you back, Dr. Root. He emigrated back to New York. Every day above ground is good.
I'd like to mention one thing.
Sure.
We learned today two things: calcification, septation, mucin are bad.
Yes, correct.
All righty, thank you.